We are back about a week later with our patient who was having myofascial pain in her lower back and is feeling a lot better, which is good. So we're going to do a repeat treatment, cupping, myofascial work, and we're going to add a little bit of traction mobilization to get all the lumbar segments moving and happy, and then we're going to send you on your way. Sound good? Okay, come lay face down, please. I can already tell this feels much smoother, which is nice. Got good symmetry through the sacrum, maybe slightly posterior here on the right. And this whole QL and lumbar multifidus is just, you can just feel the skin moving really nicely. Up here on the left side, getting a little bit of congestion right there. Making a note of that. So let's use some cupping. Getting a little bit of shea butter on the rim of the cup. And the cup's a little cold, okay? So there it is. Cup grabs the skin and the superficial fascia and lifts it up. And then we glide the cup over the skin to stretch the fascia, mobilize the fascia, stimulate all the nerve endings in the skin and in that superficial layer of fascia. And we like to go in the direction of the muscle fibers so that we're moving lymph as well. And when we get down to the iliac crest, we're going to change direction, come more medial and lateral along the gluteal attachment on the iliac crest. Good. Nice deep breath. Good. So, since the real area of stagnation and restriction is here, I'm going to let the cup sit there for a few. And while that's doing that thing, let's straighten out our hips a little bit. So, just a little lift and a little jiggle, a little bit of traction, and the hip will just fall into an open position. Many people, when they first lay on the table, they've got their hip adductors engaged a little bit and their knees are a little too close together for you to be able to really feel and mobilize what the sacrum and pelvis are doing. So here's my next spot, right here, adjacent and just below the right SI joint. So I can feel the iliac crest here, PSI is here, sacrum is here. That means this is the SI joint. And on her, it's like this. It's like 2 inches long. And don't forget, it goes in deep. The whole surface of the joint would be like this overlap of my fingers. It's not just right there. So a little bit of gentle work on this textural trigger point at the attachment here. Still being mindful of that cup because I'm going to move it in about 15 seconds or so. Just a little more fascial work through the glute. And a nice deep breath. Good. And when you take the cup off, don't just pull it straight off. Squeeze it so that releases the pressure on the skin. And you can see a little bit of stippling here, and she's going to have a little bit of a purple mark there for maybe 2 or 3 days. So when you are making a decision to cup someone, doing it in an area that's generally covered by clothing is better. And if you're going to be cupping someone somewhere that's not covered by clothing, they need to know that it's going to leave a purple mark. So they can say, yeah, I don't really think that's a good idea for me right now. I have an important meeting or whatever the case may be. So since we've got the cup right here and that sense of a fascial trigger point in that glute, let's open that up as well. Deep breath for me. Good. So while that's doing its thing, let's take this time to get into the ribs. Mobilize that rib lumbar junction right there. So with my left hand, really kind of gently lifting the ribs up and out and gently pulling that lumbar spine toward me. So we really want to have nice mobility right there. And we're going to do that bilaterally.
That's always tender.
Mm-hmm. Okay. Feedback from the patient was that's always tender. So, good to know. So we're not exerting a lot of pressure here. I'm actually above, superficial to the tender spot, pulling the fascia around it and trying to get a little movement in there relatively without putting direct pressure on it. Okay, let's release that. Good.
Not into, just like from here all the way out there. Almost tender. Both sides.
Okay. So let's work on that. So feedback from our patient was lots of soreness through this section. Just under the iliac crest, here's the crest, and here's the trochanter. So most of this is gluteus medius muscle, and that's obviously lateral hip. It's one of those tonic muscles that's active in posture and gait all the time, because when you're walking, and let's say you have all your weight on your right leg, the tendency would be for that right hip to pop out. And it's the gluteus medius's job to keep that from happening. So in order to work it, I think of it as a triangle like this with an arced attachment at the top. So we're going to work it like a fan. Just like this, from the trochanter up to the iliac crest. I start on the trochanter here. I come superior until I sort of dive off of it. Yeah, I'm not leaning in. This does not need to be very deep. Just a gentle strokes, inferior to superior, just like that. And we're going to do that again. Really right here, right in the center of the muscle, is where I feel it the most congested. So we'll spend a little more time. And underneath the gluteus medius is the gluteus minimus. And there is a way to get into it without pressing too hard. May I have your leg, please? And what you need to do is try and just give me your leg. So this really depends on your ability to hold up the patient's leg, which depends on their size and its relation to yours. But here I've got her gluteus medius. It's got some slack in it. So you can see that I can get a little bit deeper with the same amount of pressure. And that minimus kind of is a smaller little cousin of the medius. It doesn't go as far up toward the crest, and it doesn't go as far back toward the sacrum. And on her, it's just this little muscle right here, but super important. You can really kind of sense the belly of it right here. You doing okay with pressure? Mm-hmm. Good. 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 And we don't want to drop the leg. I let it down nice and slow. And while we're here, we're going to feel those abdominal insertions, the QL, and feel that iliacus. Feels good. Okay, let's get you turned over facing the window. Okay, so we've got our face down again. We have our traction table set up. I'm going to use my foot pedal to distract the lumbar spine just a little tiny bit. We have the flexion piece open so that we can move the lower part of the table. We can move it in flexion. We can move it in side bending. And so by doing so, we're able to circumduct the lower body without having to hold up the patient or put them on their side and twist and squeeze the rib cage, and kind of, this is just way more comfortable. So got the sacrum here on the left side between my thumb and my ring finger, and I'm guiding it to induce the circumductive movement that I want it to be able to do. And as always, when I bring it through a range of motion, I want to feel where the resistance is and do a little work there to try to work through that resistance. So as I'm coming up these segments here is L4, L3. On the left side, I'm feeling a little resistance to flexion and right side bending. So we're just going to kind of directly induce that movement with the table. And you can see I'm using my knees and a little bit of my body weight to move the table. There we go. While my hand guides and goads those segments in order to go through that movement. So it's a way to adjust the segment without having to put a lot of force through it. Deep breath. And let it out. Good. Good. You got to make sure to bring the patient's spine back to neutral and lock the table down before they get up so they don't fall. When I started in practice, I made a commitment to myself that nobody would ever fall off my table. And so far, so good. Okay. Thanks for coming back in.
Thank you.
Good to see you. Have a good trip.